So thank you so much. I must thank Dr. Manoj Chawla, Dr. Purvi, Dr. Bansi. So this is a talk which is a different talk. It's on role of micronutrients and multi-component bioactives in prediabetes and diabetes. This does have some duality and conflict of interest. It's by Ever Vital Life Sciences. They make Cretlo, Benfozest, and many others, 2-MMG. And none of the content of this talk is linked to these, but please visit their exhibit booth. So we all know that unhealthy diet is a very common risk factor for diabetes and nutrition. And nutrients are very key to metabolic homeostasis. And many micronutrients have a role now, which are very well characterized as anti-inflammatory or immunomodulators. So that data is clear-cut. Obviously, when it comes to big ticket trials, the data is conflicting, but A, B6, B9, B12, C, D, E, and many trace elements like zinc, iron, selenium, they all improve immune function. They prevent excessive expression of inflammatory signaling proteins. And some of these micronutrients have been linked to diabetes prevention in type 2 diabetes space as well. Fundamentally, we all know whether it's diabetes or obesity or dyslipidemia or hypertension, fundamentally there is excess sympathetic overactivity and the entire oxidative stress redox imbalance occurs, which leads to a lot of heart disease. So clearly we have a burden where there is progressive pathobiology. We clearly have both under and over nutrition, both of which have micronutrient deficiencies. We clearly have deficient micronutrients in diabetes, and each of these ingredients have some role, good, bad, ugly, in type 2 diabetes. So burden is huge. We know that we are the largest diabetic population on planet Earth, but the biggest challenge is undiagnosed diabetes. And that is why needing preventive nutrition, whether you take it from food or, we are in an era of ultra processed food. Swiggies and Zomatos are ruling the roost, and we are depleting all the micronutrients from processed foods. And which is why nutrient supplements have a role. We also know that diabetes is a relentlessly progressive disease, and the progressive nature is very, very disruptive. Some of these micronutrients have a potential for disease progression to be halted, mainly in pre-diabetes space, worsening of insulin resistance. And there is several data, including big ticket data from US, Australia, which has suggested that. So science of nutrition in prevention is huge for metabolic health, because we are unfolded a metabolic pandemic, and diet and lifestyle has a key role in preventive nutrition, and nutritional supplements do have a role in cases of deficiencies. And if there is a lack of sufficient nutrient in a person's diet, it's important to have a re-equilibration of unhealthy diet and individualized risk for chronic disease or people who are already sick. So clearly there is a role, and that role is clear-cut, including complication prevention, and we understand that better. So let's very quickly look at micronutrient deficiency in diabetes. We have many micronutrients, including, as I told you, A, D, E, K, which have small amounts needed for cellular metabolism. We also know many of these vitamins and micronutrients are cofactors in enzyme catalyzed reactions, and if they are deficient, it leads to impaired metabolic function and later on more serious disease conditions. So we know that micronutrients are beneficial for metabolism, for gene expression, influence development or progression of chronic disease, and clearly there is a link between micronutrients and glucose homeostasis, and therefore the evidence of deficiency and efficiency of these micronutrients have a precise role in pathogenesis and development of disease. Clearly, diabetes, people living with diabetes tend to have lower antioxidant vitamins A, C, and E. This decrease in vitamin levels is a consequence, and therefore we need to manage that oxidative stress. We also know that the retinoid binding protein plays an important regulator in the adipocytokine function. We also know that diabetics or people living with diabetes have reduced levels of thiamine, pyridoxine, and biotin. And a lot of research says that people living with diabetes have hindered absorption of various nutrients, including B9, B12, and we need sometimes replenishment of the same. We also know the link between vitamin D and risk of developing diabetes and its complications with heart disease. Some studies have suggested the K supplementation may improve glucose metabolism. This remains uncertain whether it will prevent or repair oxidative damage. But one thing is clear cut, that the A, D, E, K are fat soluble. And the A, D and E, K, which are fat soluble, can bioaccumulate. And therefore we should first of all do no harm, and therefore that's important to recognize. While B and C, even if they are in excess, they are water soluble and they'll get out of the system. So clearly uncontrolled diabetes has a lot of accumulation of oxidative end products. Excessive glycemia depletes their entire antioxidant systems, and that eventually leads to both oncogenesis or cancer as well as heart disease. And therefore it's necessary to have some of these antioxidant vitamins, minerals, either through food or through supplementation, and probably have an impact on complications. Even micro minerals, we are looking for an iron mukt and iron deficiency mukt Bharat, but we know that iron is very important and micro minerals are very important. The role of iron is very controversial in diabetes. Based on diverse ethnic and geographic populations, there is evidence that iron intake contributes to oxidative damage. There is a cohort in the Maastricht study which clearly links iron metabolism abnormalities like ferritin, transferrin, iron, non-transferrin bound iron with type 2 diabetes. So that data also exists. Zinc and copper are more controversial because of micromineral differences, because we know zinc is a very good immunoregulator. We saw it in COVID times, but also has an insulin-like action both in vitro and in vivo experiments. And there is a linkage that zinc intake could reduce type 2 diabetes mellitus by 13%. And if you elevate those levels, there is a 64% increased risk with type 2 diabetes. So there are studies on both sides. But one thing is clear cut, that if your zinc is deficient, the IL-6, which promotes inflammation, is negatively correlated. And a lot of meta-analysis which has been done in copper says that there are higher copper levels present in people with diabetes compared to healthy individuals. So clearly there is some data to suggest that zinc and copper in right amounts in right people may have a role. But again, it's not something where verdict is out. Manganese intake seems beneficial. There is data both, but mainly in the women, mainly the postmenopausal woman, and they have studied urinary manganese even in the hypertensive population. And therefore the data keeps emerging. Scientific evidences keep emerging. And there are three groups now we have: positive connection, no connection, and controversial. And clearly we recognize that B1, B2, B6, B12, niacin, biotin, pantothenic acid, folic acid, and C, and minerals like chromium, magnesium, manganese, selenium, vanadium, and zinc, all of them have either positive role, no connection, and controversial role. So let's look at some of these connections. In the first category with positive association is B9, E, D, B1, K, and zinc. They clearly have an impact. We know B1 or thiamine is crucial for breakdown of glucose. And Professor Michael Brownlee, who suffers from type 1 diabetes himself, who is at Einstein, who gave a Banting lecture, did a lot of work on a fat-soluble component of B1, which is bentophyothiamine, and showing data on its role on microvascular complications. But there is no direct proof to show that uses of thiamine can manage glucose levels. But there is clear-cut role that it may modulate lipid biology, and it has been suggested that riboflavin and thiamine may even prevent gestational diabetes. K definitely has a role on glucose metabolism. And K has a critical function in lipid biology and glucose biology. And clearly in pre-diabetic population, there is a role for K. And a lot of work in older women with K and men improve insulin resistance. Over 36 months, there is an impact on bone density and fracture rates. And a lot of ligand capacity to regulate blood glucose has been very well regulated. Zinc, I did allude to, it does impact carbohydrate and fat metabolism. It's complex with chemical ligands. It has some anti-diabetic action, and it does improve the cellular signaling for glucose control. And as I told you, zinc and copper in combination may have a role in complications. E has been more complex, because we know that E had some role as an antioxidant, but most of the studies, including the HOPE study, showed that it was as good as a placebo. And therefore E went out of the system, though E still continues and E still has some role in the brain and in its neuroregulatory capacity. As far as folate is concerned, we understand folate is a critical, crucial metabolic pathway, mainly because we are in an environmentally polluted environment. Our air is polluted, food is polluted, water is polluted, and we know that in epigenomics, folate actually is an anti-aging compound. It improves insulin sensitivity. It clearly is a recognized feature, and therefore it's very clearly not only just hypothesis now, and good work coming from many parts of the world, including B12 folate work coming from Dr. Yagnik's group, which clearly show that there is a role of folate and lower chance of acquiring type 2 diabetes. So that data is very clear cut, and that's something which we recognize. And therefore folate has a therapeutic role in glucose metabolism. So clearly folate in diabetes or complications will stay there. Vitamin D is very well established in type 1 diabetes, and in type 2 diabetes space also there is a link. And in fact, if you see all the big trials of vitamin D in diabetic space, people have done well. In B12, it's a little more complex. B12 consumption fits in two categories. That is no bearing or link to olfaction. We know the adenosylcobalamin and methylcobalamin are the two active forms of B12, and generally known as cyanocobalamin. And we have clear areas where there is a lack of it, like megaloblastic anemia, hyperhomocystinemia, cognitive problems, sleeplessness, neurological problems, and CV disorders. We also know metformin blunts B12 absorption, and therefore there is a role in B12 space. B12 can have a role and has links with things like insomnia. B3, B6, C, and vitamin E are controversial. We know B3 is useful for TAG and LDL while raising the HDL levels. It can ward against atherosclerosis. We know it may have an anti-angiopathic role, but it's a very controversial vitamin. C was held in the polluted environment. C is more of an immunomodulator and reduces oxidative stress. B6 data in diabetes, again, at the pancreatic islet level has been very well documented, and clearly that data is very clear. So remember, folate and B9 has attracted a lot of attention in the scientific circles. So has B6, and a water-soluble B vitamin does have a very good metabolic signaling impact. A does have a role, but A can lead to toxicity. So unnecessarily supplementing those individuals may not be good. There's one more study which clearly suggests that there's a very complex relationship between B6, specifically the PLP, the pyridoxal 5-phosphate, and diabetes. And we know the PLP has a role in diabetes, and this biologically active form of B6 may have a direction to control more than 160 enzymatic processes in various neurobiology, in physiology, amino acid, carbohydrate, and lipid metabolism. So clearly, for controlling antioxidants, there may be a role for PLP. And therefore, lowering that, and it's often lower in diabetics, we may need to resurrect that cofactor, and that's something which we know. Chromium again has been studied, but its usefulness in diabetes is mainly in hospitalized space, because often people who have enteral and parenteral nutrition have a chromium relationship, and we all know that it's a very good modulator for potentiating insulin action. Our daily chromium doses are very well known, and we do live in chromium depleted spaces. There's a lot of clinical evidence on chromium. For brevity of time, I'm not going into details of that. And clearly then there is a role for bentothiamine. We know that this is a prodrug of B1, which is fat soluble. Now remember, B1 is normally water soluble, and it's basically a trans-ketolase activity, which is a rate limiting step for the pentose phosphate pathway. It blocks PKC, AH, hexosamine, blocks the NK kappa beta, and reduces apoptosis. It has very good neurobiological effects, and it's a perfect storm. Alpha lipoic acid, again, it's theotic acid. It's a very good mitochondrial blocker, and there's very good evidence to show that. For brevity of time, I'm not going to get details. The Sydney 2 trial was a multi-center randomized control trial on alpha lipoic acid. So we all want to age well, age gracefully, and whether you are in early life for growth and development, adult life, or older age, we need to ensure that the chronic oxidative stress and the immunology which is aging, can we change that? Can we make a difference? And I think many of the micronutrients and antioxidants have a role in maintaining longevity and improving homeostasis. And they all impact mitochondria. And I'm not going to go into details of mitochondria, but all the food we eat gets converted into ceramide and diacylglycerol, and it basically causes mitophagy and causes a complete mitochondrial disruption. It impairs mitochondrial respiratory capacity and impairs and harms the metabolic health. So lifestyle changes, and I'm almost done in a minute, I know my time is up, is fundamental for prevention for mainly all non-communicable diseases, and diabetes is no exception. And we need to understand that sometimes we should not just go by large big ticket trials in nutritional, because today's world we are consuming a lot of ultra processed food, and sometimes the right nutrient at the right place as well as some nutritional formulas may have a role. Thank you so much for a patient hearing.